Just a reminder, question cards are on your tables, and there will be an open microphone soon. But I do have a question. Dr. Easter, I'm going to start with you. Lonnie King is a friend of mine, and I've given him a hard time for a number of years about putting medical students and veterinary students in the same class for antibiotic stewardship. Now, I noticed in your report from the AAVMC and APLU, your joint report on antimicrobial resistance, your task force, I noticed that you talked about creating several university-based pilot projects focusing on combating antimicrobial resistance. Can you talk to me more about that?
The realization is that many of us operate universities that have both the agricultural component, the veterinary component, as well as a medical school, as well as pharmacies, pharmacy schools. So the opportunity is there to put together consortia that can take advantage of all of the expertise in these different domains to do work in these areas. So APLU and AAVMC continue to have conversation about how we might build those kind of entities and how we might bring that proposal forward.
Any specifics on what's happening? Can you
Not
share?
At this point, we're in the process of developing a concept paper, and that's about where we are at this stage.
Well, this question is for Dr. Stevenson. As veterinarians, we prescribe antibiotics according to animal weights, and these dosages are very specific. Why is this not also the practice in human medicine? And do we worry that this may contribute to resistance by over or underdosing?
Yeah, that's a very good question. There was a very recent editorial that discussed, when a lot of the human drugs go before the FDA for approval, they get approved for skin and soft tissue infections or community-acquired pneumonia, even though these drugs are designed to treat very highly resistant pathogens. And there's just two new drugs that were Zerbaxan and Avicaz, the brand names, that were just recently approved. And what the FDA approved them for and how we actually use them is very different. So I know our practice is very different from yours in that we use a lot of drugs for off-label use. And so the criticism in this editorial was these drugs ought to be approved for what they're going to be used for. So Zerbaxan is used for multi-drug resistant Pseudomonas. Avicaz is used in our hospital specifically for carbapenem-resistant Enterobacteriaceae that are not treatable by any other means. So that's part of the reason. I think we take drugs that have we think are selected place to be used, and we use them in that setting, even though they're off-label and don't follow the FDA guidance. I think as far as the dosing, we're getting pretty aggressive about trying to have very good dosing guidelines with weight-based dosing for most drugs. So I think there are fixed dose schedules, but I think for the most part, with our parenteral drugs, at least, we're trying to do more weight-based dosing. So I don't know if that answers the question.
So I'm going to ask kind of a generic question to all of you, and I stole this from Dr. Dunham. She talked about breaking interdisciplinary barriers, and she talked about getting the whole of society engagement. So how do we break interdisciplinary barriers for future collaboration, and how do we get whole of society engagement? So that's a two-part question.
I'd like to know.
I'm really asking how we work together.
I'd like to know the answer to that question, too. My experience so far has been disappointing, I guess, when I've been at some of these interdisciplinary conversations. I guess I've said it. I've outlined specifically in Minnesota what I think needs to be done or understood, or actually in this case, what we don't know. And the comment was, well, we'll go find it in the literature. And I know it's not there. So as a member of the general public, not the veterinary or medical profession, I am much more optimistic. I see those two groups working together well when I see it.
I might comment from an academic perspective. One of the characteristics of universities is that faculty tend to be rewarded and recognized for their contributions within their discipline. And it's been very difficult to actually develop a robust environment where interdisciplinary collaboration is recognized. We've struggled with this at the University of Illinois. We've made progress, but there's still a lot yet to be done. And particularly within communities that are somewhat disparate, where there's a logical reason for two areas to work together, it seems to happen. Engineering, food science, food engineering, it just makes sense. But surprisingly, in this area where you would think there would be obvious collaboration, it's been difficult to foster.
What I would say about that, I think part of it has to do with incentives or disincentives, I guess, in terms of promoting collaboration. The good news is that a lot of the research funding now is really looking at networks and multidisciplinary groups that can collaborate effectively on whatever the research topic is. So that's something that's promoting this. But I think, as Dr. Easter mentioned, we tend to work in silos in terms of what's our specialty area, and intellectual property and our ideas and research ideas we tend to be somewhat protective of, and so the idea of maybe sharing those across borders, that's maybe a disincentive for collaboration. But I think the environment, or the atmosphere, the culture, if you will, is moving much more towards cross-disciplinary, collaborative kind of projects.
I think we have a question from the audience.
Yes, this is related to amounts environmentally of antibiotics that are present in different areas. Tetracyclines are used, if you look by tonnage, as sort of the most commonly used class of antibiotics in animal agriculture. The Oxitec mosquitoes that are going to be released for combating Zika are dependent on tetracycline to survive. That's the way they were engineered in Britain, where they're not using tetracycline for animal agriculture. And the assumption is that there's no environmental availability of tetracyclines from agriculture for those mosquitoes in southern states like Florida. Is that a safe assumption? Are the levels of things like tetracycline so low where a release like that wouldn't pose a danger? I mean, it's a little bit different than the resistance question, but it's kind of concerning to someone who's naive about this, about what the levels are like in different places.
I guess as the token environmental scientist, I'll try to answer that. I know almost nothing about the environmental fate of tetracycline. I work with somebody who knows probably as much as anybody in the world, so assuming I understand his students' seminars, tetracycline, and I think most physicians know this, it's very photolabile. So there's tetracycline toxicity. If you take tetracycline and you go out in the sun, it'll start breaking down in your body and things go sideways. So I don't know anything about those mosquitoes. So I can't comment on that. But tetracycline, to me, if there's sunlight, it's not going to last very long. So I can't even see how those mosquitoes would work because they're going to be exposed to sunlight, obviously. Residues in general of antimicrobials are exceptionally low. There's two factors. One is if they're natural antibiotics like tetracycline, they tend not to be recalcitrant. They tend to degrade. The other thing is there's a huge dilution effect at all times. So I want to say that tetracycline in the environment won't be a problem, but that's a guess.
Thank you. Another question from the audience. What do we know about antibiotics in effluents in other countries, so India, China, etc., in water used for bathing and drinking as sources for resistance that finds its way around the world?
Oh, good. I can answer that one. That's a good question. So when I talk about truthiness and that sort of Stuart Levy antibiotic use leads to resistance, I think there's a lot of truth to that, just not complete truth to that. Other countries, to my knowledge, China and India, use antimicrobials without prescription. You can go to the local pharmacy and get them off the shelf. Well, you can do that here also with tetracycline. You can get tetracycline off at the pet store. So anyway, other countries, there are examples in the literature where they're exceptionally high. There was a river in India where they had 2 milligrams per liter of ciprofloxacin in the river. Therapeutic levels are about 1/10 of that. So that was a very frightening antimicrobial resistant river. I think that was an outlier. I hope that's an outlier. As far as drinking water goes, I guess one of the truthiness things that worries me to a great degree is as a culture we have this mentality that if we detect it, it's a problem. And what is literally happening, I think, with the environmental chemists is we're now detecting and quantifying reliably levels of things in the environment that are not of concern, which is good news, but we still have this culture where we found it, let's worry about it. I'm certain that's the case with antimicrobial resistance in drinking water. We can now measure it, but it's crazy low. So I do not think that's a major problem, although my colleagues in environmental sciences disagree with me. I'm in the minority on that opinion.
Thank you.
I can make one
Go
comment
ahead.
about that. I'm not an environmental scientist either, and but just having, I know that a lot of the components for antibiotics are manufactured in China, and then they get sent to India where they're formulated into the final product. And there's data that show a lot of environmental contamination from those factories and during the production process. But I mentioned that we were just in Shanghai at a One Health, Ohio State One Health workshop with a number of representatives from different universities, and there were some environmental scientists there, and they talked about their experience of looking at soil sampling and water sampling. And I was astounded at how much resistance they're at least detecting extended spectrum beta-lactamase producing Enterobacteriaceae, and then maybe of more concern is this polymyxin colistin resistance gene called the MCR1. Found a number of isolates with that. And I know in other studies that I'm familiar with in different international settings, the same thing is there. The question is, as you mentioned, is how much of that contributes to human and animal health.
I guess suddenly something has come to me that I think is important. About 4 years ago, there was a study that came out where Chinese researchers developed a technique to find recombinant DNA in the environment, which is connected to an antimicrobial resistance gene. And they found absurdly high levels of this recombinant DNA throughout a handful of Chinese rivers. When we repeated that study with their technique, all of our samples were negative. So I do think there are some very big international differences.
A question for all of you. The conclusion of many who hear the message that use does not lead to resistance will draw is we should not endeavor to reduce use. If this is a take-home message that you would like this audience to accept? And then why?
I'll start. No, I don't want this audience to do that. Another word that I like is nuance. Antimicrobial resistance is a nuanced problem. It's more complicated than you take it, you get resistance. I guess I've talked about poo. The analogy I like to use is with sex. If you say that you have sex, you'll get babies, that's kind of true, but also not always true, right? And there are things we can do to enhance it, and there are things we can do to prevent it. And that's the analogy I like with antimicrobial use. Okay, we can use antimicrobials, and it'll lead to resistance. There are things we can do that'll make that even worse, like we can overdose antimicrobials. We can, whatever that might be, and there are things we can do to prevent it.
It's maybe a naive viewpoint, but I struggle with that statement. It's the evolutionary goal of a microbe to survive, and it's going to attempt through whatever processes it can mount over a long period of time, even generations, eons if necessary, to develop a strategy for surviving in the presence of whatever's toxic. So the notion that there's no development of resistance is a difficult one for me to accept.
What I would say about that is I think there is a misconception probably that antibiotic use creates resistance. I think there's a lot of good studies to show that in the microbial environment where there's competition between microbes, a lot of the resistance mechanisms were already developed long before antibiotics ever hit the scene, if you will. And we know that the first antibiotics, penicillin and others, came from molds and so forth from the environment. I think what we teach in our courses and when we talk about this is that there's two things. One is most of the resistance that develops in the hospital is due to gene transfer. It's not new genes being created. It's resistance genes that are in one species or one pathogen that get transferred to another. And then when you add to that antimicrobial pressure, you're selecting for resistant populations. And I think that, but there are cases, I know in one of the hospitals in Ethiopia that I'm working with, they have carbapenem-resistant organisms, but they've never used carbapenems in their hospital, and they're not available in that city. So I think that's what I would say is that antibiotic use creates the pressure on the microbial population. And if you have places in the hospital where there's lots of antibiotic use, like the intensive care units, there's very many studies that show that the resistance profile you see is parallels the antibiotics that are being used. So the antibiotics, the organisms are resistant to a lot of the antibiotics classes or drugs that are being used in that population. So.
I have to add that I've spent a bit of time in the last couple months in the European Union, and I went to a conference where a lot of the other countries in the European Union stood up and talked about their antimicrobial stewardship program, especially targeted at animal agriculture. And one of the things I found is they wanted to claim success. We are successful because we have reduced use in antimicrobial use in livestock. But not a one of them talked about what did that do to the bacterial-resistant disease in humans. And I only point that out because I think we have to be really careful setting our goal as reduction of use, because there are unintended consequences with that, as we know. I think our goal ultimately has to be reduction of bacterial-resistant disease in humans, and responsible use of antibiotics is certainly one of the tasks underneath that goal.
Yeah, and I think, our goal, we've talked about this, that if our goal is to just get to contrast, in the human side, there's this, in infection prevention, there's a zero goal. The idea is let's reduce the number of hospital-acquired infections to zero. And, there's a debate whether that's attainable or not, but that's certainly a laudable goal. From the antibiotic side, our goal is never going to be let's reduce antibiotic use to zero. I mean, if that's the case, we just take all the drugs off the formulary and quit using them. But the drugs certainly play such an important role in the management of patients. The big thing is, I think, optimizing, what's the right drug, the right dose, and particularly, I think, the right duration, giving drugs for much shorter periods of time than in the past we've felt that we need. And all of those things will help to reduce the pressure on the microbial population.
I think we have a question from our audience.
Yes, I have a question. I think Dr. Stevenson answered my question partially as I was waiting to speak, and that was the emergence or the increased resistance among the Enterobacteriaceae that you showed during your presentation. And then I quickly reviewed the NARMS data, and that, of course, using culture sensitivity testing has not shown much change over the last decade. So I think that you answered that partially because of the increase in the genetic selection or the genetic transfer of resistance among the organisms in the hospital setting. But I might have you comment on that NARMS data and your thoughts on that, if you're familiar with that. And the second question is for Dr. LaPara, and that's since I'm a producer and a veterinarian that works with large production units on the beef side, what's the effect of composting manure on antimicrobial or antibiotic degradation before we spread that onto the fields?
Yeah, I'm familiar with the NARM state. I'm not. I don't know that I'm expert enough to make comment. I guess the only thing I would say with a lot of these surveillance systems, we're always dependent on the sampling method and so forth. But I probably shouldn't try to make a comment more than that. I don't, because I don't know enough about the data.
As far as how does composting affect antimicrobial resistance, my guess, I've never seen any data on composting. That would be really good research to do. My guess is if it's high temperature composting, it would have a substantial effect in decreasing antimicrobial resistance. If that's a economically feasible approach to dealing with animal manure, that would be one that I would think would make a big difference.
Another question from the audience for the whole panel. Do you think throwing enough money at the problem will make it go away? Don't we wish? All speakers ask for more research and more data. Is it really just more money, or will it take something more to solve this? Everyone is smiling.
I'll struggle with this. I'll take a crack at this. You all have heard the phrase, money doesn't buy happiness. Yeah? Yeah, there's studies that come out that, from scientists, yeah, people with more money are happier. So yes, more money will help. It needs to be spent appropriately. I don't think lack of money is the real problem. We need more research. We need really good scientists doing really good things, and it needs to be a lot of us, in my opinion, on the environmental side. I can't comment on the veterinary or the human health side. But in antimicrobial resistance and understanding of the environmental chemistry of antimicrobials in the environment is in its infancy. If 10 years ago, I could have counted the number of papers of antimicrobial resistance, well, hands and toes. Okay, it's really in its infancy. So the field needs to grow. I think there's sufficient money. We need talent more than money.
I think the real opportunity that research provides, particularly fundamental research, is to discover phenomena that no one knew existed, and then have opportunity to create ways to take advantage of that. So I'm not convinced that throwing a lot of money is the right answer. As he just mentioned, it's the appropriate kinds of research and manage that process.
And I would add to that, I think what Dr. Dunham mentioned in the last presentation is, I think using the resources wisely, the right kind of research. But another big thing, I think, is sustainability. And I think, particularly on the international front, if you create a program, you fund a program in an international setting that brings in the right equipment and the reagents and whatnot, and you see an improvement, as soon as the funding leaves, the program ends and people drift back to the same practice. So I think more than anything, if we find things that are improving whatever program it is, we need to focus on sustaining those programs.
Another question for you, Dr. Stevenson. Has any data been segregated on rate of non-compliance in human antibiotic prescriptions? I think you gave some data on that already. And if so, the effect on resistance patterns.
Yeah, so I'm assuming the question might be if somebody doesn't take their full prescription, or I don't know if specific studies like in the outpatient setting. I'm sure there are supporting studies. I just can't think. I know that, just for example, there was studies in kids where they showed that kids who took antibiotics for ear infections or whatever, and then you subsequently looked at them, cultured their nasal pharynx, they were more likely to have drug-resistant pneumococcus in nasopharynx. And I think patients who've had prior antibiotic exposure and is often a risk factor for them being colonized with different drug-resistant pathogens. So, but I don't know of specific studies offhand. I'm sure there probably are where you're linking not taking antibiotics for the full course or whatever.
So are we concerned about colonization of drug-resistant bacteria, or are we only concerned if it causes pathology or disease?
Well, the problem with colonization from both an infection prevention and people tend to get infected with organisms that they have, their endogenous flora. So, that's true. If you've looked at MRSA infections, for example, when somebody develops an MRSA infection, if you have colonization data, it's often from the organism that they were colonized with that develops the infection. And we do know people who are colonized also become a reservoir for transfer. So if I'm colonized with MRSA, for example, I may not have an active infection, but if I'm in the hospital, I might be a source of causing that infection, that organism to get into someone else where they can become infected. So, but I would say there's been a lot of controversial studies about the impact of decolonizing patients, both pro and con, and that's still, I think, up for debate.
Interesting. One last question I think we have time for. And I was listening to Dr. Bowden speak, and she talked about fears and wants. So concerning, and this is for all of you, concerning antimicrobial resistance, what are your fears and your wants from your respective fields? So name me one fear, and if you had anything in the world, what would be your one want? I won't hit you if you name me two.
I guess one of the things you'd want is that decisions always be based on science. And that, I think that's been brought up several times today. And the opposite side of that was putting in place regulations or requirements that really have no impact, but create cost for the consumer ultimately.
I guess my fear, I kind of alluded to, is that we have, we're reaching the post-antibiotic era where we're going to have patients that develop infections that we can't treat. And so that, I guess, is one fear. And if I had one want, I think that's a tough one. So more money. No, I'm just I think trying to...
typical faculty member.
Yeah, right. Yeah, typical academic. More funding, yeah. No, I think I think the vision that's kind of been described here as far as, particularly on a global scale, that we can collaborate in a way that we can effectively address the problem of global antimicrobial resistance. And I think sometimes I've worked in infection prevention for a lot of years, and you do all this stuff within the walls of your hospital, but we don't live in a vacuum. What's going on in the community and nursing homes and other hospitals and community physicians' offices and, the veterinary offices and agriculture, it all impacts each other. We need to, my want, I guess, would be that we can develop a system that addresses all of those issues.
I guess my fear and my want are the same thing. My fear is that the environmental component of antimicrobial resistance will continue to be ignored or neglected. And so my want is that it not be. I think there are some very cost-effective ways that... So antimicrobial stewardship is primarily about limiting antimicrobial use and doing it more appropriately. When you get to the environment, it's about dealing with the consequences of antimicrobial use, which is inevitable, I think. So I think we can make some big improvements, so that's my want. I'd like to pursue them.
I think we should give our panel a wonderful round of applause.